So this is Simon's new baby, no CAD-CAM needed. We'll introduce it to the OVC. It's a hybrid ceramic, and we'll talk about the procedure. So that to me doesn't look like Simon. He looks like a scientist there, but nonetheless, when I first heard that Simon was involved with it, I was really keen and excited to learn about it. And it's one of his amazing inventions. And not only is the OVC, but you get all the other components, the stretch wedge that we talked about earlier, the unique band, the OVC matrix band, that's specific for that particular quadrant. So, for instance, a lower molar, a lower left, you have a band for the lower left. The 6 and 7 are the same, and there's one for the right, and there was one for the upper. And there's also premolar OVCs as well. So you can see here you've got the OVC molar, OVC premolar. We have what else we've got there? I don't know. Oh, the stretch wedge, yep. So with the OVC, you can see the OVC has a hard shell, and that's been heat cured. And B, the soft part is identical to so the actual A and B, the hard and the soft part are identical materials. It's just that this is nice and squishy, so that's where you actually then seat it over your tooth, and then you can then adjust it. But so we've got a hard shell and if you don't damage it, literally everything's all finished for you, the whole surface, the occlusal surface, and the soft part is for manipulation onto the tooth. Each of the OVCs comes in 5 sizes, so there's extra small, medium, large, and extra large. The most common are probably the ones small, medium, and large. 2 shades, A2 and A3. It's for the patient and for the dentist, it's convenient because now they always market about you don't need CAD-CAM. It's a single appointment, high productivity. It doesn't take you very long. Once you master the technique, you can do one probably 30 minutes, 40 minutes, an hour, depends on where it is. It's aesthetic, it's tooth coloured, and it's simple. It's easy when you bond it on. It's easy to adjust because you just need generally discs or diamonds. We need a tabletop preparation, so you're not doing your traditional preparation. So you're not cutting so much of the tooth away, and the minimum is about 1.5 millimetre preparation, and then beveling the margins. Durability, we'll show you the tables about the strength, extremely durable. And as a dentist, we like to do things that are financially rewarding. So there's no lab fees involved, save time saving for the dentist and the patient, no local anaesthetic, no temporaries, multiple units. I did 7 on a patient in 4 hours, and I thought that was quite rewarding. So a clinical case, a lower molar with a buccal cusp that remains. And look at the OVC, 1 Visa crown. This one looks like it's been stained, and you can almost, you go and look for the join, and it's almost invisible. In fact, Adam Dowdy from New Zealand has done over 600 or 700 cases, and he's one of the clinical advisors for the company. And this is won a 2-year recall, showing that there was no changes after 2 years in the product. So patients, obviously time is a big thing nowadays for patients. I mean, if you can offer 1 visit to a patient, they'd rather not come back for an appointment. So according to Sirona, 85% of patients prefer a 1 visit appointment. That's why they sort of market their CAD-CAM units. So OVC, you don't have to buy the CAD-CAM, you can offer that as well to the patient. From our perspective, obviously 1 visit is better than 2. We're booking about an hour per appointment, as opposed to 2 hours for a CEREC unit, or if you're you're sending it to a traditional lab, there's no need for 2 appointments. Certainly, I think there's a huge benefit after you've done a root canal. Then you don't have to place a band, you can place an OVC. We'll talk about our deferred crown cases where, patients that they've put off the treatment because of the cost factor. Now you can reactivate those patients. In fact, the company has if you ask them, they're going to produce a letter that you can then either send to your patients to reactivate the patients for that purpose. There was a dentist on the Sydney course yesterday. She just attended a recent seminar. she sent a flyer to all her patients about the ones that may put off the treatment because of cost, and she found that she was able to reactivate a lot of those patients. So she ordered the large kit, and she used literally I think she only had one left. I think there was 24 in the kit, and she used 23 of them. And she was really absolutely excited because the fact that those patients who had put off that treatment now had an option. And patients, you take an after photo, and patients just love the fact that it's tooth coloured and you haven't given them like a PFM. So, case selection, teeth that's structurally weak, those fragile walls that you need to overlay in case they fracture. No longer do you have to do large MOD buccal or lingual composites. You've got an option now to restore teeth that are missing cusps. Cracked tooth syndrome, sometimes the diagnosis of a cracked tooth syndrome is sometimes difficult. So sometimes I'm really reluctant to do too much work. I don't want them to spend $1,800 and get the wrong diagnosis. So it's easy to swallow if you offer them something lower cost, just in case you've misdiagnosed it. But nonetheless, you can still treat cracked tooth syndrome using this material. We talked about RCT, patients that have had severe occlusal erosion, through acid wear. You can raise the vertical dimension, because when you start talking about doing lower veneers, for instance, you have to increase vertical dimension. And so if you're quoting something like $1,450, $1,850 per indirect restoration times 8, I think sometimes offering that lower cost is more acceptable to the patient. Hypoplastic molars on young patients, an option, because it's more conservative. And again, those patients who can't afford our traditional crowns. This was really interesting. This is the load testing. So this is having a tooth that's an extracted tooth and with a restoration in place, and looking at this little metal ball bearing and basically driving it through that restoration and fracturing it, and looking at the forces that takes to fracture that restoration. Have a look at the a composite, and look at the EMAX crown, and look at the one visit crown hybrid. It's an in-house study, but even Simon, I talked to Simon about this, and he was surprised by the results, the strength of this material, whether having that composite component could absorb some of the stresses. In fact, I used to think that EMAX crowns were reasonably strong until I had one fracture recently. I had a root canal treated tooth, beautiful crown made by the lab, and he fractured one of the cusps, and it took part of the tooth with it. And I've got that case that I'll show you that I restored with the OVC. So it is a hybrid material, and I think the fact that you've got the composite absorbs some of the occlusal stresses. Low wear, you've got the zirconia particles to make it stronger. You can easily adjust it, so it's not like cutting zirconia or cutting a ceramic material. It actually cuts quite well with a diamond, and the beautiful thing, you can repair it in the future if there's a fracture or if there's a proximal cavity in that tooth, you can restore it without having to replace that one visit crown. It doesn't come with stains or fissures, so you can choose, if you want to make them look more natural, you can actually then use some composite stains to tint it. Bertolotti, everyone knows Ray Bertolotti, who visits Australia regularly. He likes to promote, obviously, tabletop press. Why? Because there's less chance of you damaging the pulp through deep preparations. So we look at doing a tabletop prep and then beveling the margins to hide that join and to make the bonding a little bit better. So, with an OVC, you need a minimum of about 1.5 to 2 millimetres occlusal prep. People talk about bonding, and I know I've had this personal experience. This is a study looking at the strength in bonding to dentine, we're not talking about OVC, but it's been shown that direct restorations, direct bonding is superior to indirect bonding. So, and Hing and I think we practice with EMAX, and I've actually has anyone had EMAX tabletop crowns come off? I've had it, not long after the patients, we've inserted it and they've said they've flossed it off. And that goes with bonding, because direct composite bonding is generally a lot stronger than indirect restorations. And so with the OVC, you're adopting this type of procedure. So let's look at the procedure. So the first step is to determine what size OVC that we need. So in the kits there, this is called the selector key. This is the one with the little hole I showed earlier. It's not very obvious here, but there's actually little steps in this key. So you probably can't read it. That says XL, extra large, and then it gets a little bit smaller. That's large, medium, and small, and extra small. So there's a little key that you use, and you actually insert it interproximally between the two teeth. And the one that obviously fits, you want one that sort of is still loose, because once this picture shows you can't drive that selector key because the extra large won't fit. So you'll be selecting large for this particular case. If you're going to do this procedure and you don't want to order and have them all ready, then what you can do is use a registration material. You can take an impression over the patient's teeth, and then you can turn that upside down and use that as a guide to measuring, and then reorder that material. But these selected keys generally come with the kits. The minimum reduction is 1.5 millimetres, but the clever thing is that Simon's given us these replicas. The replica it's basically a duplicate of the actual hard shell. So it's a more or less a reduction jig. So you place it over your prep, and then you ask the patient to bite down, and if you pick that up with tweezers, you should be able to pull that through freely, right? Then you know you've prepped enough. So if your patient bites down and you see that jig move, you know there's interference there. So you've just got to prep it a little bit more until you find that just isn't interfered with when the patient fully closes. Occasionally though, you might bite down, you think you've got enough clearance, but the actual replica shifts. So generally that happens if the opposing tooth may, for instance, be out of alignment or might have a plunger cusp. So if that's the case, you've got enough prep there, but have a look, you might have to reduce the opposing cusp. So this has got to almost sit passively when the patient closes. And then if it does, then you're sort of confident that the OVC is not liable to shift or fracture in the process. The jig the replica acts as a guideline, because when you place it over the prep and it sits passive, then you've got a relationship, because if this is the OVC, you know how to seat it because you just compare it against the adjacent marginal ridges. Right? So it gives you almost the trial. It's almost like the try-in for the real thing, not only being a replica. So it comes in a box, as you see the one that last way, and you can see these are all A2. You can see these have the different size of small, medium, large, molars. And when you open up each kit, you'll find all the ingredients. Everything's all there in the kit. So here we've got the band, we've got the stretch wedge, you've got those subgingival wedges there. And if you don't use these, you tend to then accumulate them, right? You keep them. You have your replica, and the OVC is actually in this little area here. So you just have to tell your staff not to throw it in the bin when they open the lid up, because it's in that light protected pocket pouch there that you just pull that open and it's sort of sitting in there. We'll talk about the band. The band is specific for the tooth. So you can see that the band is 30 microns in thickness, so extremely thin, no different to those V3 bands. The top of the band, the occlusal part, is beveled, so it sort of bevels out, and the reason for that is that then allows you to seat the OVC without having the sides of the bands collapse, right? So this is why you have a bevel. But the bevel also, you can actually lay that against the marginal ridge of the adjacent teeth. It gives you that control, the height control. This part is crimpable. So once you seat the band around the tooth prep, you squeeze this, and you squeeze it at the end first, and then this tightens the band around the tooth. So this is essentially, once you get that in place, it's really quite easy procedure after that. So here you see the band on the tooth prep. The main thing to look for when you place it and squeeze is that there's no gap on the lingual. So what happens if you have a gap there? Obviously, when you place composite, it's going to get into that gap and you're going to create an overhang. So you want to make sure that when you place the band, and that's what we'll be checking in the workshop, that you've got to tighten it. You haven't tightened it far enough. You just tighten it until you see no space between the band and the tooth on the lingual. You may have some spaces here, but this will be taken care of when we put the stretch wedge in place. But look for the gap on the lingual, right? No gap. So we pinch from the outer end and squeeze it nice and tight. And once that's in place, then we place the stretch wedge. And the first thing we do, remember we talk about pre-stretching it. So you get the stretch wedge and you may activate it 2 or 3 times to stretch it. So it ends up being a lot longer than the original length. But when you do that, it actually is a lot stronger. So according to Simon, is that it actually has a better ability to create tooth separation. So we found that sometimes if you didn't do that and then you went to place that between the teeth and pull it out, it can break. If it breaks, you haven't pre-stretched it, right? So you've got to remember the step that pre-stretching it helps to make it stronger, and that's how it functions. And when you pre-stretch it, it thins out so that this central part is really thin and you can floss it between the band and the tooth and get it between there. If you place the band and the band overlaps it, you need to sort of move the band over a little bit to allow room to floss that band through, to floss the stretch wedge through. So you place 2 stretch wedges, but you don't fully pull it yet. Right? Now, a lot of people say, why? I showed you that earlier slide about the ability of the stretch wedge to create the separation. But if you pull too hard initially, sometimes what happens, your prep is sort of quite deep, because don't forget, you may have removed a large restoration, so your proximal boxes have this deep cavity. So this is supposed to show, if you actually pull it, you can actually dent the band, right? And we don't want that, because if you look from the occlusal view, you've got this indentation, and if you fill that up with composite, you've got a dent in your tooth. So that's why we don't get you to pull on it immediately. Nonetheless, you still have to pull on it until there's no space, but we don't get you to fully activate the stretch wedge until this area. We want to fill this area first before you fully activate that stretch wedge. So if you look at it, if it's correctly placed and pulled, you'll find this one has the indentation in the band, and you can see this one now hasn't distorted the profile of the band. If you took a cross section, if you're able to look through that band, that's composite. That's filled that occlusal deficiency in that distal box, because then the stretch wedge wouldn't then distort the band. It's working against it. You have a question?
Do you do any proximal preparation or not?
Well, you have to be able to place the band, right? And I found that I had a clinical case where there wasn't much room to. I had a long contact. The molar behind it wasn't like quite curved. It was very flat. So the mesial surface of the stem was very flat, which means when I had a look, I thought, I don't really want to do much prep, but I had trouble getting the band down. So you have to create a space for the band. Sometimes this might be tighter than this one. I would do the harder one first. You know, it's easy to get through the wider space, but do the hard one. But that case where I couldn't get it, see, because it's 30 microns, it might fold. You get that lip, have to take it off, burnish the band. And sometimes I spent a bit of time, so then I had to deepen a little bit, so I had some space. You can also try using a metal polishing strip and create it. So once you've got the space there, it's just that you've got to then get that through there first. It's no different, you know, we've all placed, I mean, as clinicians, we've all placed bands. In fact, the V3, you know, sometimes the V3 is curved like that. Sometimes it's hard, isn't it? And this one's actually a little bit more, it's not as curved, so it's generally a little bit, the only thing is it's thin, it's 30 microns. So the other thing is that you don't want to burnish the internal of the band, because, you know, the band is designed to be smooth. So this hasn't been fully stretched yet, but there's no space. There's no space in the proximal areas, but we haven't fully pulled that yet. So the next step is we have to seal the tooth. So, because in other words, if there's a deficiency, we need to fill that in like that to avoid that, that dent in the band. We would etch and bond the tooth. Now, direct bonding, we all know how to direct bond. So you can either do selective etch or total etch. Place your desired bonding agent and light cure it. Then we place only a small proximal amount, and we stress small amount. And I've made the mistake, I put too much in. If you put too much flowable, you find you can't hold that band across, and you may take up the space of the OVC. This is purely there to ensure that when you place it, because you may have a bevel there, it's going to fill in the bevel. Then once you place the flowable, with an instrument, whether it's a plastic, you just hold the band against the adjacent tooth. You don't burnish it, you hold the band. So we're trying to create that V there to lock in that stretch wedge. Now it's no different. Now we all know that, when you place a band, when you're doing the V3, you always have to hold that band against the tooth because there's no guarantee you'll have a contact point. Is that correct? And those of you who forget that step, sometimes you think, okay, I'll place the V3 band there, place the ring there, and I've forgotten to hold the band across. You sometimes get an open contact. So it's no different, this technique. Yes?
What is the OVC made of? It's 73% zirconia.
No, 73% filler particles in a resin matrix. Yep.
Right, okay.
Yep.
So it's resin and zirconia
Yep.
in one.
Yep. It's a hybrid. Yep. All right, so does everyone understand this? Because I think a lot of dentists have trouble grasping this. So you do one side at a time. You want to just hold the band against the adjacent tooth, and again, because when you're going to pull on the stretch wedge, then this stretch wedge will go and it won't ride up, but it's also having the other benefit of filling in that proximal defect first. So you generally would use, maybe if it's a deep box, you might fill it up with composite or a bulk fill material. You do one side, and then you do exactly the same on the opposite side. Right? Once you've done that, you can then go and pull the stretch wedge, and this is what's going to create the separation. So if I pull here on this side, what will happen is that 7's moving distally. You're creating the space, and don't forget the band is 30 microns, so the harder you pull, the greater the tooth separation. Right? So pull one side and pull the other side, and now that's ready to go. Right? You can see, and as you pull, you might be pushing on one end and pulling with the other. You can, if you find that the mouth, the cheek gets in the way, you can grab that with hemostats and then push and pull with hemostats if you find the cheek is too tight. So we've fully pulled the stretch wedge, you've got the separation mesial distally, and now we're ready to go. I would then place the next step is to then place some flowable composite over the whole occlusal surface. And that's like a wetting medium. It's a very thin layer, but in case you get any air bubbles between the soft layer of the OVC and the tooth, place a very thin layer of flowable composite, but you don't cure it, right? Because it's the wetting medium. So you place that and then you're ready to take the OVC out of the container and then place the OVC into between the band. And then I would use my thumb or finger and then gradually press that OVC. And what you do then, as you do that, you find the excess, the soft material starts to ooze out between the hard shell and the band. And you get a lot of excess. What can happen when you press? A few things. You might find the fissure, the tooth may rotate, the OVC may turn, but that's easy to correct because you look at the lines of the fissures of the adjacent teeth and you can see if you push and you might rotate it, it's very easy to move it back again. When you push on this material, this soft material has a nice consistency. It doesn't rise up again. It doesn't have a rebound effect. So usually you push it down, it stays put. The guideline you have also is that the marginal ridge should be used, generally it's level with the adjacent tooth. So that's why you can see here the plastic is being held against the adjacent marginal ridge. Right? So that will tell me that now the OVC and the adjacent tooth are the identical height. Because I see in a lot of the workshops, the dentists are focusing on getting it right, but they actually leave it elevated. If it's elevated, what happens? Then I might be high in occlusion. Because don't forget your replica. Remember I said, look at the replica. If the replica sits below the marginal ridge, then you try to duplicate the replica or the initial tooth that was there. Another thing that can happen as you press, and in fact, I've actually had patients bite down on it. If you don't use rubber dam, you can actually get patients bite down. But the concern, and Simon has the concern, that if you bite down on it, you actually may cause the OVC to tip. Right? So tipping means maybe the lingual cusp will be higher than the adjacent teeth, and that means the buccal cusp sits down. That can happen. So when I do, I try to get them to do it gently, but sometimes under local anaesthetic, they can't control the bite. But it's better to err on pushing it lower, right? Because then you can be assured that maybe the occlusion will be a lot easier and you don't have to adjust it. But you do run the risk that if you leave it too high, you might have to do some occlusal adjustments. So if you get that occlusal cant in the buccolingual direction, then you have to then obviously move it back. So ideally you try to press the OVC vertically, and we don't really want to have a mesial distal cant either. But use these criteria. Marginal ridge is the same, and look for the fissure rotation, and you want to have the buccal and lingual cusp horizontal. And that's why it's important, when you place the band, it should be horizontal. So I use the edges of the band as a reference point for the positioning, the occlusal positioning of the OVC. Because if you're sloppy and you place the band and the band's on an angle, you're sort of going to place the OVC. You lose your reference point. So try to get the band correct first before you place the OVC. So once we're happy with the position of the actual, go back. So we're happy with that. We think that's in a good position. Getting back to, I usually try and clear some of the excess on the outside of the band because I want to see the edges of the band for my reference point for positioning the occlusal. But you don't have to, because you can spot cure it. So that hole in that selector key, if you place it over the middle of the tooth, you cure it, you count like 4 or 5 seconds, then that OVC is cured and won't move. You check that with a plastic that doesn't move, then you've got all that time in the world to clear your excess around the edges. So the main area you want to clear, because this has already been created, the anatomy, it's hard to create that roundness in the marginal ridges, so you want to use some sort of fine instrument and clear that out. So I would scrape that away, go around the areas where you think it's hard intraorally to get access to, so that's sometimes in the corners. The buccal excess, it doesn't really matter because you've got good access to there. Your band was tight, so you generally don't get an overhang, right, if it's pulled tight. You may have some excess here, but just try and clear up as much excess as you can. If you find this, that flowable oozes up and it's quite, it's low viscosity, you can blow air and blow the flowable away, but you want to clear it up before you do the final curing, because then obviously you minimise the post-treatment adjustments. So then you then do the full cure. I would do each cusp separately, 20 seconds, and then you take the band off. You take the band off and you've got generally a little bit of excess that you may have to then obviously remove with a disc or with a fine diamond. Go back because you may be concerned. Simon doesn't feel it's necessary, but because it's the oxygen inhibitor may be covered with a band. But I generally would still recommend placing some glycerol or KY jelly around the joint and just I would then cure 20 seconds on each side. If your curing light has those turbo cures, I would use the turbo cure to just try to maximise that cure through that hard shell. So we can adjust it with diamonds and discs, and then hopefully we're going to beautifully finish. And I don't know if you've looked at that model. Everyone looked at that tooth model on the bench. That's been beautifully polished. If you were to take the teeth out, you would find that if the band is untouched, you're going to get this beautiful smooth surface, and you won't be able to feel the join where the margin of that tooth and the OVC begins. Lower right molar. This is obviously looking quite close, and you can use you can place that during before your prep to obviously separate the teeth and then not cause damage to the adjacent tooth. It's better to put maybe a wedge guard. You check the replica, make sure it's free of the occlusion. And now this one looks as though it's been bonded. It's quite shiny. We look for no gaps on the lingual. And the stretch where it hasn't been fully pulled yet, but you can see there's no spaces here. Looks like flowable, tighten. We do it each side first, and then pull the stretch wedge to tighten that, create more separation. Place the One visit crown in and all the excess oozes out. Spot cure it, and then we just have to refine the restoration. This one looks as though it's been stained. You can see the tints, but quite a nice looking restoration. Sam Coe, right, one of the guys here. Sam from the Young Dental Hub. This is his case. Where's Sam in the room? Do you want to explain this case, Sam?
Nothing quite better.
So Sam, a lower molar, 6-year-old molar, lower right. What size was it?
Small.
Small, okay. So Sam's put it through the band, stretch wedge. He's done it under rubber dam, which is nice. And look at the anatomy. You carved that really well, Sam, didn't you? So if you get the occlusion right, that means you don't have to touch the occlusal surfaces and you just have to polish it. Most of the research and studies look at marginal leakage around class 2 restorations, and in fact they say we can never avoid marginal leakage in the proximal boxes. So you think you've done the best restoration. That's why we generally bevel. If you leave butt joints, there's a higher probability of marginal leakage. Simon's studies, he looked at 5 teeth with one visit crown. These were only spot cured, right? They were spot cured for 5 seconds before the final curing. All right, and they do all that thermocycling, put in the dye. There was no evidence of any leakage, which is pretty good. And the full curing one. So another 5 OVCs were fully cured, and then they were tested for marginal, and they found no micro leakage in either cases, which almost defies what the literature is saying with our class 2 restorations. So that's pretty exciting. Jan Thompson from Denmark, looks like he's emulated he saw what a job Sam did, and he's going to copy what Sam did. So this is the same tooth, I think. There's the replica. So you can see, once there's clearance, have a look at that. You're going to mirror that effect. The marginal ridge of the replica should be the same as that. So therefore my OVC will try to identify that when we place the OVC. There's the OVC. And x-rays, always the x-rays look quite nice when you look at them. There's that beautiful contour that's created by our band.
Do you have to build up those balls, or you can just go straight from them?
Yeah, you can do it. I suppose it depends on your curing rate. If that's 4 or 5 millimetres, I would probably tend to, I like using a bulk flow flowable just to build it back up, because unless you're convinced your light will cure 5 millimetres, are you convinced? Yeah, okay. So you have to look at the depth. I don't know the depth of this case, but then, you've got your replica and you can sort of judge it by that. That was a good question. So Dr. Shamlian from the United States, he's done a premolar. So it's an upper 5. Another example, this is it looks like a 6. You can't see where the join is, but the radiograph. And I haven't done it, but you can use the OVC as Pontics. Who's excited? Prof Ian Myers, who always lectures about the worn dentition, I spoke to him about this, and he's doing some teaching on this, but he said that now he's got almost a preformed tooth to create that Pontic, and so he looks at that being a benefit for his, he lectures about the GC Everstick, that material, and he feels that's a benefit to his practice. So here's the Pontic, same thing, you have the reduction guide, and you place the Pontic and remove the excess. So you've got tooth already prefabricated. So if you go back and look at your practices, I know these are just some figures that have been thrown around. So if you had consultations on a weekly, you might have some practice where you've got some associates. If you recommended 15 patients per week to your patients, I know I don't have a 100% success rate. If your success rate is only 55%, that means you've got half of those patients don't accept your treatment plan because they said they can't afford the crown. If you were to reactivate those patients, so send them letters or whatever and talk about that there's a newer material that we can charge, it's lower cost. If you were to reactivate 30% of that number on an annual basis based on 15 consults a week multiplied by that, right? You've got here 720 a year, but you're reactivating then 97, close to 100. If I'm charging $950 per unit, you're actually then recouping about $90,000, which is quite significant. So I think it's important now you've got an option about reactivating, because most of our software, you can then track down all those 613s or 615s that didn't accept your treatment plan. Yep.
Yeah, regarding the item number, you said what? Like 613, 615, but what?
615 is for PFM. Yeah, so 613 is for a tooth coloured, yep.
Yeah. So what item number can you
Yeah, look, I generally use a 613.
and reduce the amount?
Yeah. So you have to decide, how do you position, if you're adopting OVC in your practice, that's where, how you're going to position it. Because I'm a CAD-CAM user, I now, I've already paid for the CEREC machine, so I feel that it doesn't really interfere with that type of treatment. At least I've got another option to the practice. And now I look at it, a crown would cost $1,850 and an OVC would be $950. So I go through, what's the difference? Well, a CAD-CAM, I've got a camera that takes a photo of your tooth and it will make a custom fit crown to fit your tooth. Whereas I've got a newer material that I take it out of a packet, I measure the size of the tooth, then I actually mould it and shape it to fit your tooth. Do you have a choice of materials? Most patients don't really make a big decision, but I leave it up to them to decide. And I tell you, it's almost going like 70-30 going towards an OVC because of that cost-saving benefit. And plus, they always ask you, what's the gap? The OVC, if you're charging $950, your gap will be significantly less, and they love that. We had, I think, we had a patient, Hing, didn't we? I did one. She got back about $600-700. She was only out of pocket $200. So, because we just put it through the HiCaps machine. So you have to determine, what you do with this. If you don't have a CEREC machine, it's even better, because then you have no conflict. In the sense you haven't spent that $200,000, but now you've got a choice of offering. Do you offer a large composite restoration now, or do you have something? Because the thing with a composite is that a patient doesn't see a difference between an MOD, buccal-lingual composite, as opposed to a occlusal. To us, we know the distinction, right? We spend 1 hour doing a large composite, but they still think it's a filling. And we try to differentiate that I spent 1 hour doing that, therefore I'm going to charge $450, and I'm going to go, oh, that's a lot of money. And then you're too scared to tell them that's $450. But now, a point of difference is that this is a crown. And I think to them, it's easier for them to understand it's not just a filling. So on that basis of trying to market an OVC, I think it's a lot easier, because no longer do you have to say it's a larger filling I have because it involves more walls and blah, blah, blah. But then they say it's a filling though, and they don't understand item numbers. But if you said, no, this is actually a crown and it's made in a laboratory and I'm going to put it on, it's $950. But if you want a traditional gown, I can give you one for $1,850. And they go, no, I'll have that, the $950, thanks. Yeah.